All right, good afternoon. I like that. Thank you. Welcome to Sharks third. I don't know if we can call it third annual, third of 4 years. For those of you that have not observed before, just a brief outline on structure. We'll have each presenter, aka victim or prey, have 5 minutes to present their research application, and then 5 minutes for the sharks to feed off of the results. After the 4 applicants have presented, the sharks will actually go to stage right and make a decision. We will actually hear from the winner from last year's sharks. We'll have a 3-minute update on what their research has accomplished over the year, and then we will present a prize to the winner, which will include a $5,000 check, which will be in the mail. So to begin, but there will be a prize. All right, so first to introduce the honorable sharks for 2023. Let me introduce them. First of all, Dr. Brian Richmond, to the left. He's the president of the Southeastern Surgical Congress, professor of surgery and chair of surgery at West Virginia University. We learned today that he is a prior wrestler, which means verbal full Nelsons are allowed. He is an MBA and can see through your business proposals. Beware. Dr. Patricia Turner, the executive director of the American College of Surgeons, a minimally invasive surgeon, educator, research, and MBA, possibly the quintessential shark. She knows and recognizes quality, as we just heard. She may bring out her Stop the Bleed kit once finished dissecting your project. Dr. Manny Zervos, professor of surgery, surgical oncology, director of Cancer Center Service Line at Eastern Carolina University in Greenville, North Carolina. His H-index is 38, and his publications have been cited over 4,500 times. As the Southeastern Surgical Congress treasurer, he writes the checks and will be very critical of who deserves to win. Oh, got a hand clap for that one.
If anyone.
If anyone. Dr. Janavi Srinivasan, professor of surgery, program chair for 2021 Southeastern Surgical Congress, Emory Department of General Surgery program director. The same fear the residents have when they see her number on the caller ID will be the same fear you will have when facing these sharks. Thank you, sharks. Dr. Liu.
Thank you, Dr. McLaughlin. Excited to introduce our first victim. This is Dr. Sagar Bakshi from Emory University School of Medicine, presenting a proposal on the demonstration of a novel thrombolytic agent in vitro and in vivo study. Careful, Dr. Bakshi, don't make the blood too thin. The sharks like to bite.
Thanks, Dr. Lowe. I'll try my best. First of all, I just want to say thank you to all of you for coming here, and thank you to the Sharks, of course, for giving me the pleasure to speak to you guys. My name is Sagar Bakshi, like Dr. Lowe said. I'm coming from the Georgia Institute of Technology, School of Mechanical Engineering, and Emory University School of Medicine, Department of Surgery. So my talk is DINAC, the future of thrombolysis. So a little bit of background. Arterial thrombi are mostly formed really by platelets and VWF. Coagulation clots, on the other hand, are formed mostly by fibrin. These really actually account for only about 10% of acute arterial occlusions. For that very reason, TPA thrombolysis is typically ineffective for these. As you guys have probably seen, TPA really only works about 10% of the time clinically. So really, we need an alternative. Whenever we have a solution, we need a question, and this is the question right here: is there an alternative? And here's a little image of both a platelet-rich or white clot and a red clot or fibrin-rich clot, which you may have seen in surgical pathology quite frequently. So DINAC, what is DINAC? DINAC is a new pharmaceutical agent that I actually discovered recently. It stands for N-N-diacetyl L-cysteine. You can see the molecular structure here for all you chemists out there. DINAC, we have a suspected mechanism. Most likely it is attacking the VWF platelet bonds, but it is most importantly specific for arterial thrombolysis, whereas TPA is not. There is little to no effect on fibrin in this case. Yep. So of course, I'm never going to come to the Sharks without proof of concept. So here is my proof of concept. I have, of course, done some prior studies. These are in vitro studies using a glass capillary tube model, whereby I have a capillary tube with a region of stenosis, approximately an 80 to 90% region of stenosis, coated with collagen, whereby I ran whole human blood through this region. Very quickly, approximately within 5 minutes or so, you have a complete occlusion, of course, being platelet rich in nature. I then perfused DINAC through this region of stenosis and saw some pretty interesting results. I also did a pseudo ABI metric where I had a pre-stenosis and post-stenosis pressure transduction. So here you can see some pictorial results. These are images of the glass capillary tubes at various time points after the beginning of infusion of DINAC. So you can see in A, you have 0 minutes. So this is at the point of complete occlusion. You can see a nice big thrombus right in the middle of that region of stenosis. And as you go through the 5 minutes, 10 minutes, and 15 minutes, you see complete clearance of this thrombosis using DINAC. As I mentioned, I made a sort of a pseudo ABI metric. So again, this is using pressure transduction post over pre-stenosis. On the x-axis, you can see those same various time points, and on the y-axis, you have the ABI. At 0 minutes, our ABI was approximately 0.7. The blue line represents DINAC and the orange line represents the control. And as you can see, over 30 minutes, the blue line or DINAC had complete restoration of the ABI to approximately 1, whereas there was virtually no difference in control. So I'm coming here asking for $5,000. There's a reason for that. It's for this proposed study. I would like to make a in vivo mouse model. This involves isolation of the common carotid artery in the mouse. And utilization of something called the modified Foltz model. Essentially, this is a mechanical injury to the common carotid artery, whereby you perform a partial suture ligation of the common carotid in order to create a region of stenosis. And this is followed by a crush injury to expose subendothelial collagen. We will then compare high and low dose DINAC with TPA and control, of course, and perform flow measurements to see the effects and the efficacy. I'll also be looking at adverse effects. This would be the commonly used tail bleeding, as well as an intra-abdominal inspection of the mice. And so I anticipate that we will have great efficacy of DINAC. As I mentioned, we have some prior in vitro studies, and I don't suspect there are going to be major side effects at these doses of DINAC, which are approximately 5 to 15 millimolar concentrations. The significance of DINAC, of course, is that it is specific to white clots or most arterial thrombi. Most importantly, we can likely extend the intervention window of these acute thromboses from the time of disease. Of course, you guys know approximately 6 hours after a complete thrombosis, and organs suffer irreversible ischemia. By extending this period, we have more room to perform interventions. And this can potentially be given en route to the hospital as well. And of course, there's a large market opportunity for a drug like DINAC. The current TPA market size is approximately $5 billion per year with, or excuse me, $2 billion per year with an expected 5% annual growth rate. Like I mentioned, most arterial occlusions are actually platelet and VWF rich rather than fibrin. Given that about 10% of those are actually fibrin rich, DINAC will cover the remaining 90%, making it approximately a $2 billion market size. So just to close, I want to say that DINAC lyses platelet-rich thrombi. We all know time is tissue, so we must save tissue with early reperfusion.
Take it away, Sharks.
So first question, from a clinical perspective, since you're talking about white clots that are primarily platelets, have you considered the possibility that as the clot lyses, you'll suffer problems with distal emboli, and how do you plan to avoid or study that?
Yeah, of course. So unfortunately, I don't have enough time to show videos of the lysis here, but we actually get dissolution of the clots into very, very small, not visible pieces. So there are not large microemboli that are coming off of this. It's really a complete dissolution of the clot.
So you said that you considered that this might be something given en route to the hospital. Is your impression that you'll be able to safely just give an IV push? Or
Yeah, and
what-
so
what
that's
would
actually
your-
part of the study I'll be doing in this in vivo mouse model is comparing a directed catheter application of this versus a systemic IV application. I think, of course, this is just suspecting that I can reach the appropriate doses giving a systemic IV injection.
So let me get this straight.
Here comes the sharks.
Your intention is to sequester a $2 billion market using a compound that you quote unquote found?
That is indeed correct. It's actually an interesting story how I found this. All of my work relates to the different types of clots that form, of course, between platelet-rich and fibrin-rich clots. I was actually looking at N-acetylcysteine. As you guys know, there are some preventative or prophylactic effects of N-acetylcysteine on thrombosis. In the process of doing this, I came across a batch that actually happened to lyse platelet-rich clots extremely effectively. So, of course, I ran over to the chemistry department at Georgia Tech and ran it by the chemists there. And they actually found that this was a stable derivative of N-acetylcysteine. It's actually a dimer of it called Dynac. And that's how I discovered Dynac.
So show me the money. What is the cost of Dynac compared to TPA if you're going to end up generalizing this to a large market?
Yes, of course, it's not being produced in large quantities at this time, but even so, at the current state, it is approximately 1,000th the price of TPA. This is actually a naturally occurring biologic compound found in very small quantities in the human body. And so for that reason, it's actually quite cheap to make.
I would just comment for the audience that I don't really care how effective this is at lysing the clot in this mouse model. I'm relatively sure that ultimately the mouse is not going to do well.
Well, actually, I think the mice will do quite well. I'll only have ischemia time of about 30 seconds or so. So it's similar to
Are
what
they
we do
really
with
going to
karate.
do well? I think you're terminating them at the end of it, right?
I am. Unfortunately, I am.
Any
How-
other comments from the Sharks?
Last question. How complex is the process of generating it? You said it occurs naturally, but in small amounts in the body. How is the actual generation process undertaken
To manufacture it.
to manufacture?
So it's actually very, very similar to the manufacturing of N-acetylcysteine. Obviously, is a pretty big market already. Like I said, it's a stable dimer of N-acetylcysteine. So just with some temperature manipulation, you're able to create Dynac quite quickly.
Last question. In your proposal, you write that you're going to establish this safety of the compound using bleeding time. Is that measurement good enough to determine the systemic or the safety of the compound, or do you need to do something more sophisticated, like a TEG?
Well, that's another large topic that I can discuss at another time because TEG does not actually appropriately measure platelet function due to artificial activation. However, I will say yes, in virtually all mouse models currently used, tail bleeding is by far the most widely used model for bleeding time.
But is bleeding time the right test?
Yeah, it definitely should be it'll be arterial bleeding time in this case from the tail artery. And so these should be platelet rich clots that are being formed. We will also perform venous hemorrhage testing in order to assure that there are no effects on fibrinogenesis.
Thank you, Dr. Bakshi.
Thank you all for listening.
Next, we welcome Dr. Aimal Khan from Vanderbilt University Medical Center, presenting a proposal on assessing the impact of tension on colonic anastomoses. Hopefully you won't fall apart like an anastomosis. Can you all feel the tension?
Is that's to go forward and stuff? Okay. All right. Thank you all for the opportunity to present my proposal here. I don't have any disclosures. So I'm going to start with story time. This is me as a young attending exactly 2 years ago, not too far off. I just finished my colorectal surgery fellowship and was ready to take on the world. A simple case, 50-year-old man, otherwise healthy, recurrent, complicated diverticulitis, decided to take him to the OR for robotic sigmoid colectomy. Surgery went really well, and then the time came to create an anastomosis. And this is, the dreaded part of that, the whole surgery where you're thinking about what can go wrong. I'm supposed to have a video here, but I guess it's not going to play. But it just shows basically the anastomosis creation from this gentleman. It was supposed to be a baker into an anastomosis. The one thing I did not like about when the anastomosis was created was the amount of tension that was there on this anastomosis. Now I had done everything I can in textbook to make sure that this was a tension-free anastomosis. I had mobilized the splenic flexure, I had taken the MV, taken the MA, scored the mesometry, the whole thing. But I still call my two partners, and both of them respected surgeon, 10+ years of experience. I'm like, what do y'all think about this anastomosis? The answers were 180-degree opposite of each other. I'm pretty sure all of you have been in this situation where you're like, okay, you know what? One person's telling me something, the other one's telling me something else. So I'm like, okay, after the end of surgery, we all decided that, or towards the end, we all decided that this was appropriate enough, and I'm saying appropriate with air quotes for the sharks who can't see me, appropriate enough tension, and we were just going to move on. The person eventually did well, but that kind of left me a little wondering. So I called Dr. Fleshman up. So Dr. Fleshman has been a storied colorectal surgeon for 30 years. I was like, he's probably seen it all, done it all. He probably has some solution for me, some magic device that can measure tension on these anastomoses. And the resounding answer was a big no. So again, I'm asking for something that all of us fundamentally understand is key to anastomosis creation. Methods and the way they measure tension was by asking the surgeon on a 1 to 10 scale if there's tension or not. Again, the same subjective experience we've been doing for 130 years. So if you think about it, we have two set of problems. We do not have a clinically applicable mechanism of measuring tension, and we don't know the impact of tension because, if you can't measure something, you can't really study it. These are the commonly available force sensors, which are used for tension measurement on the, in the market right now. Just for comparison, I'm a big guy and it's bigger than me. So that's that. So then I called someone else up using my ping phone. This is Dr. Ji Wu. She is a computer scientist, recently moved from Hopkins to Vanderbilt Institute of Surgery and Engineering. I was like, I've seen some of your work on force measurement on the robot, and this is the solution we propose. So at least a lot of our practice and surgery is moving towards robotic surgery is robot-based. This is our algorithm. I'm not going to pretend I understand all of it, but she has tried to explain some of it to me. We thought whether we can look at the tension on any sort of tissue, not just anastomosis, by measuring the electricity consumption of a robot. So think when I was taking that colon down to the rectum to create it, or when you're doing a gastric bypass and you're pulling the jejunum up, or you're closing the fascia down, at the end of a hernia case, whether we can use the measurement from the robotic arms and how much electricity is being consumed to do that. So in order to do that, and I don't have this, I'll buy all these gadgets with the money y'all give me. On the left side, you have a force sensor. On the right side, this is a 3D printed sort of scaffolding for the sensor to create this concoction. Take this concoction, put a pick colon on it, and use a robot arms. My animations are pretty good. You can measure what reading in newtons. And how many of you knew that the unit for tension is newtons? That's okay, maybe 4 people. Still, it's a room full of surgeons that create a lot of anastomoses. So the reading in newtons from the force sensors versus using our proprietary algorithm. And hopefully we can come up with a solution for the first problem of measuring these. This will have great impact. Surgery is cutting things and putting back together on a lot of different aspects of surgery. And we can solve, Halstead's a long-term problem, whether he left the anastomosis under tension. Thank you all for your time.
So as I understand it, the origin story for this concept was a patient you were stressed out about who did fine. So
Absolutely.
what's the point of doing this then? You had a patient who did just fine.
Not everyone has, though, unfortunately. I had a leak literally a month after that. I was worried about that one too. But again, it's one of those things. I think any surgeon, ask any surgeon, does tension matter? They'll say yes. And they're like, how do you measure? Yeah, just look at the tissue. Same thing we used to do with like blood supply before ICG. And even though ICG is also not a good objective metric, it still is like, I would say, some improvement over what has been done before.
So the two things I would comment on up front is, so right now you basically have an idea, but you don't have proof of concept data. And we really don't know, even if you get the proof of concept that you can measure the tension, what the tension for failure would be. So there would have to be a lot of, I think, preliminary work put in to even get this off the ground. Is that fair to say?
So we do have the preliminary data. Again, that is coming from the mechanical and computer science engineering side of it, where they've used this technique on a different robot, a commercial grade robot, to measure for force estimation. We're going to do the first work in sort of humans, because right now I don't think there's anyone working on like a gadget that will help you measure tension. And this will at least open up the pathway. Like right now I can use that machine to measure tension on all the pig colons and mice colons I want. If I'm going to not be able to use that machine in human work, there's, it's not really going to get us there. So with this, we can, once we validate it, and since it's only going to be like a software, and we work with Intuitive on this through the DaVinci research toolkit, it's just going to be over there software update to all their XI models where we can calculate the data. We can take all this data from them and then looked at, so that would probably how it starts. And then, the animal studies and all that stuff will come along. But right now we need to prove that this will work on human tissue or pig tissue, which is elastic.
So what will your gold standard be? I mean, what will you be comparing your robotic electric current measurements to?
There is no, so the 1987 and 90s and the American Journal of Surgery published some papers, and British Journal of Surgery, there were some studies that looked at tension, and a lot of them were from this one group in Sweden that essentially just afterwards died out because tension kind of went, not what they used to do is they would create these rabbit colon models and then apply tension to them. But a lot of that kind of went out of favor for oxygen tension. So which was a totally different, they would essentially take out the blood supply and start measuring oxygen tension. So I think they got distracted by the tension thing and they went on tangent looking at ischemia rather than, the physical forces of tension. Like how does that change? When I spoke to Dr. Laverty, he talked about, he's like, okay, whenever you do this, look at the chemical composition, what impact it has on the microbiome, and whether it increases the collagenase producing bacteria. And I was like, how would that happen with increased tension? He's like, you have to do that. So I'm like, yes, sir.
This is the first time I've ever heard a talk that incorporates the microbiome and the DaVinci robot. And your animations were good. Your video really was suboptimal.
I'm sorry.
So let me understand this. Let's fast forward and let's say that you've established your proof of concept. Then I'm doing a low anterior resection on someone. I'm not going to call my colleagues in to look at it, but I'm going to take the robot arm and I'm going to pull on the anastomosis to a certain, would you say newtons?
Yes.
Yeah, newtons. I'm gonna generate some newtons and determine. And then am I gonna do that up until I pull my anastomosis apart, or is there going to be a threshold where I'm going to say, oh, this is safe?
Yeah. So you're going to take the proposed colonic segment that you're going to anastomose to the rectum, hold it in like a bipolar forceps or Cartier, take it down there, sort of do like a mock, how we do with like JPUG with all those things, whether it's going to reach, check the reach, so to speak. When you do that, the robot should be able to give you a reading. This is about 5 newtons of force. Now, based on all the groundbreaking research I'm going to do with this money, is going to tell you whether 5 newtons of force is the right amount of force or it's too much, because let's suppose at 3 newtons, there's 50% chance of, leaks from all the studies by Khan et al. So that's what hopefully we're going to make and grow towards in the next few years.
And you're going to check the newtons of force on the anastomosis at post-op day 7 and 10 when leaks are more likely to happen than post-op day 1 or 2?
That's why we will definitely do animal studies, afterwards. So what we know now that at post-op day 4, the collagen remodeling is probably at the highest, and from 4 to 7, by 7 day, you have basically gained almost, a colon without any anastomosis compared to a colon with anastomosis. By post-op day 7, you have reached almost the 80% tensile strength of that. So where, and with leaks happening somewhere around the same time, how does all of this go into interplay? And truth be told, we just don't know. We know tension has a role to play. We just don't know how, when, how much is too much, and how little is good.
Thank you, Dr. Khan.
Thank you.
Next, we welcome Dr. Allison Smith from Louisiana State University, proposing inflammatory and microbial profile of peritoneal fluid from trauma patients following damage control laparotomy. Dr. Smith, you may need damage control after the Sharks are done with you, but don't worry, you won't be the first and certainly not the last. Good luck.
Good afternoon. Thank you all so much for this opportunity to present to you my proposal. I have no relevant disclosures. So the background for my project stems from the peritoneum, and we all know as surgeons its important role in the wound healing response, and also the detrimental effect that the peritoneum can have in the generation of cytokines, in particular pro-inflammatory cytokines that can lead to complications that patients experience after surgical procedures, such as anastomotic leaks, intra-abdominal abscesses, and also systemic complications such as respiratory issues. So this dynamic environment has not been well studied just because it is such a challenging environment to determine from a clinical standpoint exactly what goes wrong when and how we can intervene to help prevent these complications that afflict our patient population. So therefore, we hypothesize that the immune profiles of the peritoneal fluid following abdominal insult will vary depending on patient demographics, the immune response, and the microbial environment as well. So from this project, we generated 2 specific aims. The first was to compare the inflammatory profile of trauma patients after damage control laparotomy to non-trauma patients who undergo damage control laparotomies. The rationale for this is knowing that even though these patients may be undergoing similar procedures, there are differences in terms of what these patients are experiencing prior to the surgical intervention and their post-op management. And then the second specific aim will be to determine the presence of microorganisms in the peritoneal fluid following the damage control laparotomies for both of these patient populations. So this is my proposed project for this funding proposal. So we would enroll ideally 4 patients in each group who are undergoing damage control laparotomies. We would perform collection of the peritoneal fluid at 6 different time points during the initial surgery, and then as the patient is in the ICU up until the patient returns to the operating room for their next surgical procedure. From that, we will do 3 different types of analyses. The first will be a multiplex analysis, which will be looking at 10 different cytokines that are known to have an important role in the immune response and also can be detrimental when patients fail to heal. The second proposal will be to look at the microbial culture. So we will plate the peritoneal fluid and we will analyze it to determine what type of bacteria are grown from it. And then finally, we'll perform flow cytometry, looking for different markers that are important for immune cells, for leukocytes, for macrophages, and in particular, looking at the difference in the phenotype of the macrophage, as we know that the M2 phenotype of the macrophage has been shown to be important in the immune healing response. And then we will also look to see if there's any other immune cells, such as adipose-derived stem cells or other stem cells that could be important in the wound healing response. So I just wanted to share with you that we did get IRB IBC approval at our institution. So I have 4 patient scenarios where we initially performed some of these analyses on. So our first patient was a 28-year-old man with a history of morbid obesity. The patient was a approximately 500 pounds, who underwent, he was motor vehicle collision, polytrauma. His worst injury was a traumatic brain injury. However, when the patient presented, he did undergo a negative laparotomy. He remained with an open abdomen with a temporary abdominal closure in place for 14 days due to high intracranial pressures. The patient had many infectious complications, such as ventilator-associated pneumonia, bacteremia, and long story short, he eventually was transitioned to comfort care. When the patient went back to the operating room 14 days after his initial laparotomy, we did collect some of the fluid, plated it. We did not find any microorganisms, and out of our 10 possible cytokines, we found that the patient had kind of minimal levels of about 7 different cytokines. The next patient was a 31-year-old man who had a history of a previous laparotomy from a gunshot wound, also had an incisional hernia repair with placement of a synthetic mesh, who had another abdominal gunshot wound when he presented to us. He underwent exploratory laparotomy, extension of lysis of adhesions, excision of his mesh, and he eventually underwent a small bowel resection with anastomoses. He eventually was also found to have a colon hematoma that then progressed to needing a colectomy. He was left in discontinuity for a period of time. We did collect some of his peritoneal fluid as well. No microorganisms, but we did find that he had about 8 different cytokines, and he had higher levels of IL-4, IL-6, and IL-8, which is kind of a mixture of pro and anti-inflammatory cytokines. Next 2 patients, 28-year-old man, multiple gunshot wounds. He underwent an XLAP. He had a very complicated operative course, including missed urethral injury leading to a necrotizing soft tissue infection of his peritoneum, abdominal compartment syndrome, and he eventually underwent small bowel resection. And then, unfortunately, the patient did expire. We collected fluid from him as well during one of his reopening cases, and we found that he had a mixture of bacteria, gram-positive, gram-negatives, anaerobes, and he had 10 different cytokines, in particular high levels of IL-6 and IL-8, both pro-inflammatory cytokines. The last patient was a 60-year-old man who had a gunshot wound to the abdomen. He underwent an XLAP, small bowel resection, colon resection. His post-op course was very complicated for anastomotic leaks ×3, fascial dehiscence ×2, and now he is an intercutaneous fistula. And his fluid showed that he had very high levels of IL-8, but interestingly had no levels of IL-6, which had been previously associated with anastomotic leaks in the literature. And then this patient also grew out lots of different types of bacteria. So my pitch to the judges of why you should pick me is that we have some promising pilot data already from this study. This award would help me to complete this project, which is a junior faculty aspiring to be a surgeon scientist. This would help me along my way. I do have a strong mentorship team at my institution and other institutions that I work closely with. I do have institutional support from my university, from my chairman in form of a lab tech who helps me, but I'm the only one in my division who would be attempting to get extramural funding from a government source, NIH, or a KOA award or DoD funding. For me personally, it would help to improve my publication track record. And also I have been an SESC member since I was a resident, and this is something that I can help to mentor other young faculty trying to do something similar. So with that, I thank you all so much.
So
all of your justifications make it difficult for me to be very aggressive in my questioning. You're a young faculty member, you need publications. You've been involved with the SESC for years. You're just so likable. I have one question. I read your experiment. I'm not sure what your control group is going to add. I think it may confuse things more than elucidate what the cytokine response is. And why not propose a very limited animal model, cecal ligation and puncture, and a lavage to sort of get your preliminary data and focus before you take this to human subjects?
I think that's very good feedback. And, I would like to do this in an animal model. Unfortunately, 5,000 is not going to pay for a pig study. So I'd like to use this as seed money to then be able to get more money to do an animal study. But I agree with you. I think that moving this to an animal experiment would be the best.
Well, in all seriousness, it doesn't, this would be, you could do this in mice. Should be much, that's where the CLP model was established, and there's a good amount of data about the cytokine response in that model already, but I'm not sure that anyone has looked at it in with a peritoneal washings perspective.
So that notwithstanding, Dr. Genevieve and I both are just wanting you to help us connect the dots and how this will ultimately be clinically useful. How will you use the information? You're demonstrating differences in inflammatory response and the cytokines that you recover, but how will you use that information clinically to benefit patients?
Sure. And I think the question in terms of how this will translate is a really good one. This obviously is a very basic science experiment, but I do believe, that the more we know in terms of what's going on within the peritoneal cavity in terms of the environment, we already have enough preliminary data to suggest that there is something that happens, and it's such a dynamic environment, and it's not going to be a matter of just giving the patient one cytokine, but there's something in the environment that whatever we can do in terms of replacing certain paracrine factors that are maybe being secreted by cells, or, a lot of people are potentially putting biologic things on their anastomoses. We've talked already about Dr. Alverdi, one of the other projects, in terms of knowing that the microbe community might affect your anastomotic leak, that I do think there's a lot we don't know. And for me as a clinician, when I see patients that sometimes I don't understand why their anastomoses fell apart or why they developed an abscess, and sometimes I do understand and I don't know how to prevent it from happening, I think this could lay the groundwork for that.
Were you surprised at the different bacteria that grew? You would have thought that there would have been bacteria in all of your patients, but there weren't. So what were your interpretations around that?
Yeah, and that's a really good question. That's why I'd like to investigate this further. I have a microbiologist who's working with me, and he was very skeptical that we would find bacteria in any of the patients, and I thought it would be in every single patient. So I think, that there's something to be said in terms of, what role the bacteria are playing. And we kind of did a very preliminary plating of the bacteria, but we'd like to kind of narrow it down and see specifically which species are growing out and how that might play a role, and also correlate it with some of the patient's clinical data in terms of bacteremia.
Great. Thank you, Dr. Smith.
Thank you.
Just one thing that might be helpful for you pertaining to what Dr. Zervos mentioned is the sepsis lab of Craig Cooper-Smith has done a lot of the cecal puncture models, and may be worthwhile for you to look up just to further inform some of your research.
Thank you. I appreciate that.
And last but not least, we welcome Dr. Ryan Gedney from MUSC, who will be proposing real-time intravascular modeling with ultrasound-derived data for use in complex endovascular surgery. We're hoping not to witness real-time demolition of your model, and hopefully you can stop the bleed.
All right. I'd like to thank the Surgical Congress for the opportunity to present here today. I'll be proposing our work in the development of a novel intravascular navigation device. So minimally invasive endovascular surgery has revolutionized how we perform vascular surgery over the past several decades. There's been a drastic increase in the number of endovascular procedures that have been performed, but this is not without consequence. It's led to an increase in radiation exposure to both the surgeons and the patient. There's a good amount of data out there available that shows the correlation between radiation exposure and increased mortality, as well as the incidence of different cancers. Current endovascular navigation techniques require the surgeon to navigate a three-dimensional intravascular environment using 2D fluoroscopy. So you can see with the images here, this is really a challenge to navigate a 3D environment using a 2D reference. 2D fluoroscopy is also not real-time imaging, so the surgeon is often left guessing and testing different intravascular tracks to take until the appropriate one is achieved. This leads to increased case time as well as increased radiation exposure. So overall, if we look at the limitations of endovascular surgery, there's radiation exposure, contrast exposure. You're navigating 3D using a 2D reference. There's no real-time imaging. And on top of all that, this equipment used in these surgeries are large and cost millions of dollars. So I, along with Dr. Veeraswamy in the Division of Vascular Surgery at MUSC, have come up with what we call the Sony Nav as a solution to this. It's a medical device that has an ultrasound probe on the driving end of a navigational catheter, as well as a electromagnetic component for spatial recognition. The output from both of these components is co-registered to build a three-dimensional intravascular environment. This is radiation-free, it's contrast-free, it's real-time imaging, it offers a 3D projection, and it's a more intuitive environment for the surgeon to navigate. So we are seeking funding here today for an initial feasibility study with the goal of building an initial proof of concept prototype. This will be an in vitro system to demonstrate the functionality and efficacy of this device. We already have a proven protocol for converting intravascular ultrasound images manually into a 3D environment, but we don't have a functional prototype as of yet. So for phase 1 of the study, this will involve building of the actual ultrasound probe, which will involve combining existing IVUS technology as well as CoreTrack and Teral access navigation technology together into one catheter. Phase 2 of the study will involve software development where we take the output of the ultrasound and the enteral access navigation and combine those into a 3D environment. This will require real-time segmentation of the ultrasound images. And on the right, you can see our proof of concept that we've built thus far. So our budget proposed for this project involves spending on software development, including licensing fees and contract work, as well as purchase of the appropriate equipment, including IVUS and CoreTrack technology. So we have an experienced, motivated team ready to work on this project, including Dr. Veeraswamy and myself. I have a background in biomedical engineering, but we also have a close relationship with Clemson University and their engineering department and their software engineering resources. We also have MUSC laboratory equipment for prototyping and testing that we can use. Once we built this prototype, we plan hopeful future studies in animals to demonstrate further efficacy, and then eventually hope to work with institutional business development professionals at MUSC to plan commercialization of the technology. So overall, the development of Sony Nav is an exciting opportunity with the potential to completely change how we perform minimally invasive procedures. This will promote the well-being of both patients and surgeons, and it'll improve the efficiency and safety of endovascular surgery. This project's a personal passion of mine, and funding would also offer the chance for my own professional growth. Thank you.
Is there any proof of principle? Are there any other paradigms where ultrasound and solely ultrasound is used to create three-dimensional images?
So three-dimensional ultrasound does exist. You see it in OBGYN when you're imaging fetuses as they develop is where you most often see it clinically. But it's not real-time imaging. How those images are produced is a sweeping motion that's recorded and then converted to a 3D image. What this offers is the ability to create the ultrasound image and then register it with an actual location in the patient so that you can build a real-time image of the intravascular environment.
But when you say real time, how real time is real time exactly?
So that when you currently look at IVUS, when you're using it intravascularly, you can see the blood vessel pumping with each heartbeat. So you can see a real-time pumping image. You would see that, but in a 3D format of the area that your probe is located. Right now, what we have is fluoroscopy, where you shoot some dye and you take a picture, and then you're able to see your vascular tract, but then you can't see that in real time. Your wire then you have to guess where that goes using after you've taken the picture.
Is there any contribution by having an ultrasound on an intravascular probe to turbulent flow that would anticipate complications related to this?
So turbulent flow does exist. This would not incorporate Doppler in the building of the actual image. So I don't think turbulent flow would affect the actual image. What we do with the segmentation is If you look at an IVUS image, you'll see a white outline of the endothelium, and that endothelium can then be segmented into a 3D model. You're not actually looking at the turbulent blood flow within the lumen.
So it looks like according to your budgeting, the majority of the money would go to software development.
Yes.
So are you going to use existing IVUS technology and modify the software to generate the image? And if that's not the case, how confident are you that you can get to proof of concept within the limits of the grant and produce something that's usable for $5,000?
So the majority of the software that I budgeted out is for licensing fees for different software components that will go into the development of the software side. IVUS, the output image is saved in the IVUS machine as an image. And then the core track and Terrell access navigation system, the location of the probe is saved in that software. So if you take the output of those two softwares and correlate them to a 3D environment, you can do that in software like MATLAB is the most common software used for those kind of applications, which is what I plan to do for this.
But that data would be consolidated instantly and produce a real-time image?
Yes.
Dr. Green, Dr. Richmond, do you mind handing Dr. Green the microphone?
And as opposed to having to go through the ultrasound discovery process, would it be more efficient to try to speed up the 3D modeling so that you can create the graph that you actually need and do that, as opposed to needing to figure out how you're going to snorkel that graph through the holes of the prefab graph that's already on the shelf?
Mm-hmm. Yeah. So right now, when we're building graphs, intravascular graphs, particularly in the case of complex aortic repairs, we do use 3D reconstructions of CT scans. That is a CT scan that's done preoperatively, and you can take measurements from it, but that's not a real-time intravascular image of when you are actually performing the case. What we do now is you can overlay the pre-op CT scan in a 3D format intraoperatively, but that's not a real-time image. It's an overlay of a pre-op scan. So in order to create something real-time of what you are seeing at the time of doing surgery, it's best to do that using intravascular ultrasound.
So wall obscure your ultrasound image and prevent you from visualizing the things you need to see, like the orify of the various vessels.
It actually, in the case of calcium, it would actually help because we need contrast between the lumen and the endothelium in order to build a 3D image, in order to segment out a 3D image from an IVUS picture. So calcium would help if that transition from the lumen to the endothelium is not contrasted. I mean, I would think some luminal thrombus may affect that. Then there could be issues for sure. But in the case of most of the time when you're looking at an endothelial picture on IVUS, you can clearly see the outline.
Great. Thank you, Dr. Gedney. All right, I invite the judges to head stage right and discuss or pick whatever verb you want to use there. You'll have about 3 or 4 minutes to do that. I will invite the other Shark participants from this year back up onto stage. If you can take the judges' seats, that would be great. This year's participants. And while they're coming to stage, we are delighted to welcome back Kristen Quinn, Dr. Kristen Quinn from MUSC, who will give us an update after her award last year of the Sharks winner on the Saver, a non-invasive occlusive device to increase cardiac perfusion during cardiac arrest. Thank you, Dr. Quinn.
Oh yeah, thank you. Thank you, VAC Sharks, and thank you for the opportunity to have conducted this research. I'm Kristen Quinn. I'm a PGY3 at the Medical University of South Carolina, and I'm also co-founder and CEO of Heartbeat Technologies. The study that this allowed us to conduct was femoral vessel occlusion. Can it increase cardiac and cerebral perfusion in our porcine model of cardiac arrest? This is our pilot results. So the problem that we wanted to tackle was that cardiac arrest affects hundreds of thousands of Americans, and it's deadly. It's about 90% fatal. During CPR, myocardial perfusion rarely reaches about 30 to 35% of its normal level, and it has been found to be largely dependent on peripheral vascular resistance. We've had advances such as a Reboa that have seen success in non-traumatic cardiac arrest resuscitation. The chart on the on the right demonstrates an increase in systolic blood pressure with use of the Reboa and a survival benefit from about 10% survival to 37.5% survival, which I think all would agree is clinically significant. However, most cardiac arrests happen in the outpatient setting where it would never be feasible to have surgeons placing Reboas. So we came up with the Saver as our solution. The Saver is a non-invasive femoral vessel occlusion device that offers intuitive and secure strapping, dual pneumatic bulbs to provide femoral occlusion, thereby enhancing cardiac and cerebral perfusion, and sensors to provide real-time continuous CPR feedback. A lot of times people are doing CPR for the first time in their lives out in the community, and they don't know if they're doing a good job or not. So the Saver would offer them the ability to both improve their performance and confidence in their rescue efforts. The study that we did here, and I won't go through all the details, but we modeled porcine using adult pigs. We modeled cardiac arrest. We established multiple invasive lines for monitoring. We performed a left lateral thoracotomy, cannulated the LV, and infused fluorescent microspheres that could then be used to quantify cardiac and cerebral perfusion after the pig had passed. And what we showed, excitingly, was that external femoral vessel occlusion increased blood pressure. This is during the native heart function first. So we see their baseline systolic blood pressures compared with external femoral vessel occlusion, which reached statistical significance with 8 pigs. We showed average, that's a representative tracing of their mean arterial pressures at baseline being about 55. And with external femoral vessel occlusion, we saw it raise over 20 milligrams mercury. And then during cardiac arrest, with the LifeStat device providing regulated chest compressions, we saw that external FVO raised the systolic blood pressure again. We see the pre-arrest and then post-arrest with CPR and external FVO in the purple there, raising systolic blood pressure. And then using the fluorescent microspheres, we were able to quantify cardiac and cerebral perfusion. And we saw a 10 times increase in cardiac perfusion when the pigs had CPR with FVO, and a 50 times increase in brain perfusion when the pigs had CPR with FVO versus CPR alone. As far as safety, we also wanted to make sure it wasn't causing damage to distal musculature. So we compared histologic slides and found no significant difference in evidence of muscle damage, edema, or inflammation. And these are from sartorius muscle in those pigs. So in summary, this grant really helped kickstart a lot of the work that we're doing with my startup company and the Saver device. We've patented our technology. We should be hearing from the patent office this summer. We've raised almost $150,000 in non-dilutive grant funding to continue develop and study this device. We've been able to put in a grant to the NIH, an SBIR, STTR for a couple $100,000 to help fund, and a lot of the pilot work was able to be conducted through this grant and other grants. So I want to thank my team and my research partners, DLAR, IACUC, everybody who contributed. Thank you, guys.
All right. Well, thank you, applicants, judges, Sharks. really appreciate the effort put in and I know you are anxiously awaiting the outcome, and I was trying to think of a way to stall further, but we'll have to get right down to it. The Sharks have put their heads together and have voted that Dr. Bakshi demonstration of novel thrombolytic agents in an in vitro and in vivo study is the 2023 SESC Sharks Research Award winner. If you want to step over here, we'll give you. Congratulations. I think we'll step right up over here. All right. Thank you. Congratulations. All right, the feud is next.